Hello and welcome back to my session. We'll be talking about pancreas today, and we'll start with history as usual, followed by anatomy and functions in this session. So, pancreas, as we all know, is a retrogastric organ. It is also a mysterious organ that remained identified for centuries because of its resemblance to the mesenteric fat also. So at that time, the first person to identify it was Herophilus, who existed, anatomist and a surgeon who existed between 335 and 280 BC. So he actually discovered it. Then followed by another person called Rose of Ephesus was the person who called it pancreas. It's a Greek word and has come from two words called pan and krias. Pan means all and krias means flesh. So it was all flesh. So that's how the name came into being. Then the history is also divided in centuries. So up to the 17th century, then you have 1700 to 1800, and then 1800 to 1900, and 1900 to 2000. Basically divided by up to 17th century by the accurate anatomy. Then from 18 to 1900, it came by the organs and the functions, what happened. And then from the 19th to 20th century, it was the cellular and the molecular functions of the pancreas that came into being. So the history has got divided like this, but significant people who have contributed as the start of pancreatology was done by a person named Johann Georg Wirsung, which we all know as the Wirsung's duct. So he was the person who named the main pancreatic duct. That was way back in 1642. So that is how it started, followed by Claude Bernard. He was the person who found out the exocrine functions of the pancreas. That was way back in 1849, and was also called as the father of pancreatic physiology. So that is how it all started. But if we go by other developing features, now we come to our where we exist now in the 19th. And this thing, 1921 was Banting Best. As we all know, he was Frederick Banting, and then he was who discovered insulin. Now, this insulin has saved a lot of lives and it's still doing its job today. And then 1940 was Dr. O. Whipple, who did the first pancreatoduodenectomy. So this is a uh, significant development towards treating pancreatitis, and a very not many people like to go into it. This pancreas, it can get messy because of its autodigestive properties. So, but we'll talk about it. We'll talk about it so that we learn what it is. And so now, with the brief history getting over, we will go into the anatomy of pancreas. Pancreas, as we all know, is a retrogastric organ. In this organ is you have a head, you have a body, in between you have a neck, and then you have a tail of pancreas. It's a elongated and tapered organ, and some call it salmon colored, some say shades of gray, but it is about 15 to 20 centimeters long, some on an average, and about 65 or maybe 70 to 100 this thing grams in weight. So it is present in the epigastric region and the left hypochondral region, and the head abuts with the C-shaped duodenum, and the neck overlies the superior mesenteric artery and veins. The body has the splenic artery and vein behind it, and the tail goes into the spleen. So, in case of pancreatitis, you can have a splenic vein thrombosis. In case of splenectomy, you can have a pancreatitis. So, This is how it goes. And then you have the ducts, as we talked about, the wirsung duct, which is the main pancreatic duct, and then you have the other duct called the santorini duct, which is the accessory pancreatic duct. Now, there are some variations in the opening of these ducts into the duodenum, and so you have a major papilla and a minor papilla. This is basically a hepatopancreatic sort of sphincter there. And this papillae, the ducts, either they form up till the end and then open it into that, that is there. But if it doesn't form right till the end, then this sort of separately open up there. If that doesn't happen, then the santorini duct is sometimes obliterated by the time it reaches the opening. So according to that, you have the openings into the duodenum. Similarly, this duct in 60% of the cases is like you have the main pancreatic duct and the santorini duct opening. Then in about 30% of the cases is obliteration of the santorini duct, but the main duct opens out there. And in 10% of the cases, you have only the santorini duct that opens while the wirsung duct is obliterated, but that is only in 10% of the cases. And then if we go into the arterial supply of the pancreas, you have the celiac artery and the superior mesenteric artery. The celiac artery. So I was talking about the arterial supply of the pancreas. Pancreas receives its supply from basically the celiac artery and the superior mesenteric artery. Celiac artery gives off a branch, which is a common hepatic, which gives off a right gastric and a gastroduodenal. Gastroduodenal further gives off a superior pancreatoduodenal artery. The inferior pancreatoduodenal artery um, that comes from the superior mesenteric artery. Then you have other arteries supplying the body and tail, that is your splenic artery. Then you have an inferior pancreatic artery, which is also a branch of the superior mesenteric artery that forms three basically uh, anastomosis using the dorsal pancreatic and then the great pancreatic and then the caudal pancreatic artery. So this is basically the anastomosis, and the anastomosis of the superior and inferior pancreatic duodenal by the anterior and posterior branches form an intrinsic network that is literally adherent to the duodenum, so that during surgery becomes a little isolating. The If you have to separate the pancreatic tissue from that, that is so uh, because of this extensive network there, it's a little difficult. So what happens is, this is the arterial supply. And the venous supply is basically head is portal and superior mesenteric, and the tail and body is your splenic artery. Innervation is also very important in this case. Why is it important? Is because most of the uh, nerves they cause a lot of pain in case of pancreatitis and even in carcinoma pancreas. And basically, it is the sympathetic that causes increase in the endocrine and the exocrine functions, and that means the eyelids and the acinar areas. And the parasympathetic causes a decrease if all the endocrine and exocrine functions, and also due to its somatic innervation. And this is because the pain goes to the back. And classically, when you ask the history, which we'll talk about later, is that the pain starts in the epigastrium and does it radiate to the back? So that is why you ask for that. That is very significant in pancreatitis. Okay. So now what happens is that the functions, we come to the functions of pancreas. The function of pancreas, we have endocrine functions, we have exocrine functions. In the endocrine functions, the functions are performed by the islets of Langerhans, and that islets of Langerhans has alpha cells and beta cells and delta cells. Alpha cells we all know secrete glucagon, beta cells are insulin, and delta cells are somatostatin. Glucagon finally causes an increase in the blood glucose sugar level, blood glucose level. Then insulin causes a decrease in the blood glucose level. Somatostatins cause both, regulate both the insulin and glucagon, and also cause effect on the growth hormone and the anterior pituitary. So that is important. And then you have the exocrine functions of the pancreas, in which you have all the enzymatic this thing, release of enzymes there. You have the amylase, and then you have the lipase, and then you have trypsinogen, and then you have your chymotrypsin and carboxypeptidase. And these are basically secreted from the endocrine cells in the duodenum when it receives food, and that causes the release of secretin and cholecystokinin, and that finally causes the initiation of the secretion of the pancreatic juice that comprises of all these, like including minerals and water. So this is what is in brief about pancreas, and starting with the anatomy, the history, anatomy, and the functions of pancreas. We'll see you again in the next session.